Welcome. It is such an honor to speak with you today. My name is Abby. I am an employee at GeneDx, which is a genetic testing laboratory. I'm a genetic counselor by training, but work there as a medical science liaison, where I educate patients and providers regarding genetic testing. And today I'm going to talk to you about a topic I'm very excited about, advances in epilepsy genetic testing. Before we get started, could I just get a raise of hands of those of you in the audience that are families? Okay. And any healthcare providers? Okay. Perfect, thank you. So, I've seen several talks at this expose regarding genetic testing in epilepsy, and just want to level set why we're talking to you about this topic. And that's in part because of the integration of genetics within the epilepsy space. Now, a genetic etiology or genetic cause underlies epilepsy in up to 48% of individuals. So it's increasingly impactful, not only giving families a diagnosis, but helping drive treatment decisions. And that's what I want to frame this conversation around. So we're going to go through some genetic testing fundamentals, and then specifically in the epilepsy space, how genetic testing can be impactful, and then go through access to that genetic testing, how to get genetic testing information. And I imagine some people in the audience, some people may have had genetic testing or not, and so just going through what the different options are there. So starting with the fundamentals, I like to frame this because there's a lot of different terminology we and your doctor use when talking about genetic testing and genetic information. So first and foremost, what are genes? So genes are the instructions that tell our body how to grow and develop. There's 20,000 of them approximately in total. And I think this picture on the left, or your right, does a good job at addressing the levels of genetic information. So within our bodies, we have trillions of cells. They're the building blocks for who we are. Within each cell, we have chromosomes. There's 23 pairs in total. Half those copies are from your mom, half those copies are from your dad. And if you unravel those chromosomes, you have DNA. And DNA is sequences of A's and C's and T's and G's, are nucleotides. And then different segments of that DNA make up our genes. And genes, those segments, are the fundamental instructions for the body. And within our genes, we have thousands of different changes, many of which are natural. If you look around this room, we all look different. And that's in part because of the variation within our genetic information. But sometimes a genetic change can cause the gene not to work anymore. We call that a mutation, or more recently are referring to that as a pathogenic variant. So just want to level set as far as what the different terminology we talk about is. I like to think of it like a cookbook. So if you have all your DNA together, that is the entire cookbook. And then if you open up that cookbook, you have individual chapters, and those are like our chromosomes. And within those chapters are individual recipes, and those are our individual genes. So to address this level of genetic information, we have a lot of different types of genetic tests, some of which, again, you may have had ordered by your doctor. So starting over on the very right on the gene level, we have two different types of tests. We have a single gene test. That's where we're just testing for one gene in the body. And this might be ordered if there's a strong family history of a certain genetic change. It could be ordered if the clinical symptoms of your child or an individual are very strongly correlated with one genetic condition. But often in the cases of epilepsy, there's a lot of different genes that can cause epilepsy, different types of seizures. So often you're more so getting a multi-gene panel, and those panels can range from a few genes to a few hundred genes in the body. and it's often more well-described common genes that are being tested for. Taking a step back from that, we have testing on a chromosomal level. So a chromosomal microarray is one that's looking to see, are there pieces of the chromosome that are extra or missing, or deletions or duplications in your genetic information that are often encompassing many genes. Now, in the past, when we had a child with epilepsy and we're doing genetic testing, we might start with a multi-gene panel or start with a microarray analysis and do a stepwise analysis. But we're seeing a shift in the medical literature, in the insurance payer coverage, and the professional medical guidelines towards this testing option on the left, testing the entire cookbook. So we do that through a test called whole exome or whole genome sequencing, where again, we're looking at across all 20,000 genes in the body to see, are there mutations or changes in well-described genes or newer described genes as well, to really increase the likelihood of getting a genetic diagnosis. So to reiterate, a lot of the focus has moved towards whole exome, whole genome sequencing because of the medical literature and the professional medical guidelines. I wanted to highlight two professional organizations here. One being the American College of Medical Genetics and Genomics, or ACMG, that recommends exome testing for patients with developmental delay, intellectual disability, and congenital anomalies or birth defects as a first-line test. Let's start with the broadest test first to really increase the likelihood of getting that genetic diagnosis. We also, in 2022, had the National Society of Genetic Counselors recommending exome as a first-line test for individuals with epilepsy. And that was regardless of age or other comorbidities. So regardless if there were anything else going on in that health condition or if it was just epilepsy as the presentation. And part of the reason for this, as we're saying, is the exome increases the diagnostic rate, and we're finding can really drive treatment and management decisions for a child that has epilepsy. So for those of you that have had genetic testing before, there are 3 different types of results that we can get back. There's a positive, meaning we found a genetic change that we felt caused the symptoms that we're seeing in a child or seeing in an individual. There's a negative, meaning we didn't find a genetic change that's associated with that health condition. And then we have a third type of result called a variant of uncertain significance, or a VUS, meaning we found a change in a gene that may be associated with the health condition we're seeing, but we don't have enough evidence to support that it's actually causing that condition, or if it's natural variation or some other reason behind that gene we're seeing, or genetic change that we're seeing. The value of exome technology, so testing all 20,000 genes in the body, is that often we will test a child, for example, that maybe has epilepsy, but we will also test parents as well to see, are these genetic changes, or is a genetic change that we see in a child also in their parents? And this can be really valuable because we can get a sense of, is it tracking with affected family members? Because often these genetic changes are inherited. Or is it a spontaneous genetic change we don't see in family members and no one else in the family is affected but one, besides one child? So that can just really help improve the likelihood of getting a genetic diagnosis. Another thing that we can do with an exome test is reanalyze that data. So say you get have an exome performed and we get a negative result. we might come back and say, check in with us in a year, 2 years, and we'll relook at the data and see if we have more information that might make us more suspicious of a specific genetic change in your child that is causing that health condition. So there's more tools there, and that's why I like to call exome a living test, because that data stays with you. So let's talk more about genetic testing specifically for those with epilepsy. Again, we know that a genetic etiology or genetic cause underlies epilepsy in up to 48% of individuals. And we see genetic changes across all types of epilepsy, from generalized epilepsy, focal seizures, really across the board. Some things like age of onset, childhood age of onset, for example, makes us more suspicious that we're going to find a specific genetic condition, but that's why the guidelines recommend testing individuals of all ages, because we certainly see it in all individuals, or there's a chance across all different clinical pictures. So with epilepsy, we see epilepsy in 1.2% of the population. But I think the take-home message here is that a precise genetic diagnosis can lead to more effective treatments and help identify, treat, and/or prevent co-occurring medical conditions for children with epilepsy. And there's been a lot of research and data surrounding this point. So we know that up to 80% of cases have implications for treatment and management. In some cases, having that genetic diagnosis and the corresponding treatment management can reduce seizures by 90% in some cases. And that diagnosis, having a genetic diagnosis, can mean improved access to resources and clinical trial eligibility. So really being involved on the ground to help figure out what treatment makes sense for this genetic diagnosis. So I think this is a nice table and snapshot of some of the ways that a genetic diagnosis and a specific genetic disorder can alter treatment or management decisions. And this is just a snapshot, there's many more. But for example, with SLC2A1 that you see on the left-hand column, which is associated with glucose transporter type 1 deficiency syndrome, seizures actually respond to a ketogenic diet for that seizure reduction. Some of these genetic conditions on here also respond better to certain treatments, so recommendations for treatments or avoiding type of treatments that might exacerbate symptoms, either with seizures or other associated health conditions like liver disease. And so really, part of the motivation behind this is the numerous benefits we can get from genetic testing. So we know that we can get a diagnosis faster, especially when we're doing that more broad-based test, that exome sequencing, looking at the full cookbook, and ending a patient's diagnostic odyssey. So within the rare disease space, it often takes 5 to 6 years to get a genetic diagnosis, which can really delay that diagnostic or extend that diagnostic odyssey and cause additional healthcare costs, additional treatments, and things of the like. But having that genetic diagnosis allows us to develop a more precise care plan, maximize positive health outcomes, alert providers of additional health concerns that warrant screening. So say a child presents with seizures, but based on this genetic diagnosis, we should also be looking out for kidney problems and really plugging an individual in appropriately so they're getting the best care possible. avoiding unnecessary follow-up testing and appointments, connecting patients, caregivers, and family members to disease-specific support organizations, patient advocacy networks that can really help drive empowering families to get treatment, working with pharmaceutical companies to get plugged into clinical trials, really just connecting families for these rare conditions. This allows us to increase patient and caregiver satisfaction and qualify patients for treatment options and/or clinical trials. So finally, we talked about genetic testing, how that applies in epilepsy. How do you get this testing? What is the accessibility right now? So we are seeing more of a movement in insurance and payer coverage for exome sequencing because of the data we just went through. So over 70% of commercial health plans cover exome sequencing for children with neurodevelopmental disorders, including epilepsy, and those that meet the insurance's clinical criteria. Medicaid also is covering exome testing too, and I believe right now it's over 28 states have coverage policies for exome. Regardless, we work with families that have Medicaid to provide that access. Insurance is, I'm sure, everyone's favorite topic because it can be frustrating and different policies have different criteria, so we always encourage you to work with your doctor. We try to work with them as well to get a sense of, is this, what requirements does your specific insurance provider have? But I think the last point, for some patients, exome actually has better insurance coverage than multi-gene panels because there's that increased diagnostic yield and improving that diagnostic odyssey. And finally, support is so important, especially navigating what can be a really complex topic. So here at GeneDx, we personally employ over 100 genetic counselors to help your doctor and you navigate this information, understanding the consent process, understanding what the results are, and what the next steps can be, connecting you with support organizations, patient advocacy networks. And that's everything I have today. Thank you so much for your time. Feel free to reach out to us if you have questions at support@genedx.com. Our website has some great resources as far as what exome is. And if you have questions, feel free to come by our booth. They're in the exhibit hall, and we're happy to answer specific questions that relate to your family.